Hello, greetings to everybody from Dr. Venkataram, Mysore, sitting in India. I'm the Regional Director for ILDS, and I'm here to moderate a session on dermatosurgery under financial constraints. Let me share the presentation. Here we go. Okay. Now, this is a new initiative by ILDS to conduct such webinars under the academic committee headed by Dr. Rashmi Sarkar. A brief introduction. I'm Dr. Venkataram, Mysore. As I said, I'm the Regional Director. I practice in Bangalore at the Venkat Center. And here is my brief introduction with the different papers, over 146 of them, about 7 books. And my interests are dermatopathology, dermatosurgery, and hair transplantation. I've been a board director in ILDS in 2019. Now, ILDS represents 206 member organizations representing over 101 countries and with over 200,000 dermatologists. Our vision is to aim for the best possible skin health for all people around the world. Our mission is to increase awareness, cooperation, and communication within the global dermatology community and to promote high-quality education, clinical care, research, and innovation that will benefit the community at large by improving the skin health globally. We interact with WHO, we conduct the World Congress of Dermatology, and through the International Foundation of Dermatology, we have various educational and community activities. We observe the World Skin Health Day. World Skin Summit is our summit once in 4 years. And then we have several grand challenges in different programs in global skin health diseases. And we partner for education and care under the program JPEC. International Foundation of Dermatology is our flagship foundation. It supports the ILDS vision to ensure best possible skin health for everybody. It is through education, training, and resource development, forging strategic global partnerships, and engagement with local, regional, and international policymakers. The IFD has funded and worked with a global network of partners and distributed around $500,000. It runs Regional Dermatology Training Center called RDTC in Mysore, Tanzania, wherein it provides dermatology education to doctors, supports key personnel positions, and contributes to the continuing medical education and also the community health in that region. It has several partnerships. International Alliance for Control of Scabies. It works with NGOs to support persons with albinism, and it is involving skin health care for migrant populations. Several projects under the IFD, DermLink program, which undertakes initiatives that help patients with skin diseases in the areas of low resource. In 2022, 10 grants with a budget of $47,000 were distributed. It has outreach activities in several places, Argentina, Mexico, Cambodia, and has funded programs in several parts of the world such as Nepal, Sri Lanka, etc. It is also involved in teaching community health workers. Our collaboration with WHO ensures that dermatology and dermatologists find a voice in the global arena in several areas: classification of skin diseases, availability of essential medicines, occupational health, neglected tropical diseases, non-communicable diseases, aging and life course. We did a stellar work in COVID, and then, of course, refugee and migrant health. The International Alliance of Global Health Dermatology, also called GLODERM, connects dermatologists and trainees across the globe. GLODERM portfolio includes a mentorship program, conducting scientific meetings in several meetings such as WCD, EADV, and EAD, training through webinars such as this, and everybody can get involved in doing this. World Congress of Dermatology is our flagship congress held once in 4 years. The next one is going to be in Guadalajara in 2027, 21st to 26 June 2027. We hope to see you all there. GPEC, Global Partnership for Education and Care. It's a program to improve the standard of dermatological education and care across the world. And 2-year partnerships with a grant of $10,000 per institution is given. Several universities in developing world with the developed world can get linked, as you can see here. Then we are involved in several huge problems under the term gland challenges. These include vitiligo, atopic dermatitis, hidradenitis suppurativa, prurigo, and of course, global psoriasis at last. World Skin Health Day is observed every year. And so, ILDS, as the premier dermatological global organization, is the organization involved in all aspects of skin hair. So these are several ways you can get in touch with us, be in touch with us, and so that we can all deliver good skin health care. Now, with this introduction about ILDS, I come to today's topic. And that includes 3 speakers: Professor Patrick Huang from Taiwan, Dr. Ashique, KT from India, Professor Ivonne Arellano from Mexico. Professor Patrick Huang, here is the CV. He is a pioneer in the role of expanding dermatosurgery and aesthetics in Asia. Executive Director, Taiwanese Dermatological Society. Founder of the Taiwan Dermatology Aesthetic Course Director of IMCAS Asia, and a traveling mentor for ASDS. He is a leader in low-cost innovation, education, and surgical training. Dr. Ashique, he is the medical director and senior consultant at the Amanza Skin Clinic in India, associate editor, Indian Dermatology Online Journal, author of over 100 index publications, inventor and patent holder of a particular instrument called Ashique Skin Clamp. Clinical interests include low-cost innovation, dermatosurgery, vitiligo surgery, and technology. Dr. Ivonne, he is currently the Secretary General of ILDS, represents Latin America. She is in practice for over 35 years, formerly the head of dermatology, Hospital General de Mexico, strong advocate of ethical leadership, professional standards, and values in dermatology. With this introduction, I hand over the mic to the next speaker. You will all hear it on YouTube, and then you will see a chat box where you can write your questions, which will be answered subsequently. So learn and enjoy.
Hi, I'm Dr. Patrick Huang. I'm a practicing dermatologist based in Taiwan. Thank you so much for Chairperson's kind invitation. It's truly a pleasure to share an important issue, cost-effective energy-based devices. Over the past decades, lasers and energy-based devices have reshaped dermatologic practice, with strong evidence supporting what they can do. But these technologies also come with real-world constraints. Without standardized reimbursement, decisions are driven by capital cost, consumables, trainings, and local market realities. And these factors ultimately determine who can access and sustain these treatments. In many countries, EBDs are classified primarily as cosmetic tools. Because of this, they are excluded from national or public insurance coverage. even when their clinical value is well established. The result is a growing gap between evidence and reality. In this sense, EBDs resemble biologics in systemic disease treatment, highly effective but not universally accessible. This is why cost-effective EBDs have become such an important topic today. Cost-effective does not mean low-end, and it does not mean compromising outcomes. It means choosing devices that deliver reliable clinical value relative to their cost, that are versatile across indication, safe to operate, and sustainable in real-world practice. Ultimately, selecting cost-effective energy-based devices is not just a financial decision, it's a professional responsibility, allowing us as dermatologists to translate evidence into care that is accessible to more patients, not just a few. When we talk about cost-effective EBDs, several common misconceptions often come up. The first is that cost-effective simply means cheap. In reality, cost-effectiveness is about value, not price. A low-cost device that delivers inconsistent or unsafe outcomes is never truly cost-effective. The second misconception is that a more expensive device automatically produces better clinical results. While premium systems may offer advanced features, higher cost does not always translate into proportionally better outcomes in daily practice. The third is the belief that one premium device can do everything. In real-world dermatology, no single device covers all indications optimally, and relying on one system alone often limits flexibility rather than enhancing it. Finally, this is an assumption that technology alone determines outcomes. In realities, outcomes are driven by physician judgment, treatment strategy, and the proper patient selection. Technology is just only one part of that equation. So, how do we actually define cost effectiveness in daily dermatologic practice? First, it is not about the purchase price of the device. Cost effectiveness starts with clinical value per treatment. How reliable, reproducible, and predictable the outcomes are for a given indication. Second, we have to consider versatility. A device can be adapted across multiple indications, skin types, and treatment protocols, often provide far greater real-world value than a highly specialized system designed for a single purpose. Third, safety and the learning curve matter. Devices that are easy to master, more forgiving in daily use, and associated with fewer complications reduce hidden costs, including training time, operator variabilities, and complication management. And finally, cost-effective means long-term sustainability. This includes maintenance, consumables, workflow efficiency, and whether the devices can realistically be integrated into routine practice over years, not just during the first phase of adoption. In daily practice, a cost-effective EBD is one that allows us to deliver consistent clinical benefit safely and sustainably as to many appropriate patients as possible. One more thing, workflow is often underestimated. A truly cost-effective device should be easy to integrate. Simple setup, minimal disruption, and no need to redesign your daily clinical flow. Treatment throughput also matters. Pulse rate, pulse size, handpiece design directly determine how many patients you can treat per hour. In daily practice, workflow efficiency often determines true value more than raw device performance. The next question is practical. How do we translate cost-effective into real-world device selection, especially when new devices keep appearing? I keep it simple and consistent. I screen every device through four principles we mentioned. If a device doesn't clearly raise the value per session or lower the true cost of delivering result without creating consumable or maintenance burden, then it's not progressive, it's just novelty. Now, let's use a few devices as example to show how this works in daily practice. Picosecond laser is a very good example of device with high capital but slow payback. So from a cost-effective perspective, this issue is not clinical performance, but long-term operational resilience. RF microneedling is an example about consumable undermining sustainability. From a cost-effective perspective, these recurring and inflexible costs often become a silent tax on daily practice. HIFU is a good example where consumables are not optional, they are part of the business model. And many HIFU ecosystems rely on replaceable transducers or cartridge with a limited number of shots or lines. However, in many developing countries, the primary operational risk is not clinical performance, it's parts continuity. If the transducers are delayed, unavailable, or priced unpredictably, the device becomes unusable, regardless of the demand or clinical skill. So from a sustainability perspective, this dependency can significantly limit long-term cost effectiveness. From this example, it is clear that in resource-limited settings, we often need to redefine cost-effective. A cost-effective device is one that keeps working, low dependence on closed vendor-locked ecosystem, serviced locally with access to parts, and not fragile to ideal conditions. It also means predictability, a stable, controllable cost per treatment, not one that spikes with consumables or supply chain issues, and it must be easy to train and adapt. So staff turnover doesn't compromise safety or consistency. In this setting, cost effectiveness is ultimately resilience. If I had to choose one truly foundational laser, especially in Asian and darker skin population, it would be the Q-switch Nd:YAG laser. It addresses pigment, tattoo removal, and low fluence toning for overall skin brightening, indications that are both common and durable in demand. Economically, nanosecond laser technology is mature, requires no disposable, consumable, and is relatively easy to maintain. So these combination of clinical relevance and operational durability make it a truly cornerstone device rather than a niche tool. CO2 lasers remain essential because they bridge medical, surgical, and aesthetic dermatology. They treat warts, skin tags, and seborrheic keratosis, while also enabling excision, vaporization, and fractional resurfacing for acne scars and texture. From an economic standpoint, the laser tube is relatively low cost, and one system can replace multiple tools such as scalpel and cautery devices. Importantly, many patients are willing to accept downtime in exchange for efficacy, while preserve value per treatment. IPL is often underestimated, but it is one of the most cost-effective platforms in daily practice. With one system and multiple filters, it can address hair removal, vascular lesions, pigmentation, and photorejuvenation. In reality, IPL covers roughly more than half of basic aesthetic needs with high patient throughput. So when budget limit the number of devices you can own, IPL functions as the best true multi-tool. When the foundation is established, typically Q-switch and Nd:YAG, CO2 and IPL, the question becomes where to invest next. Phase 2 is not about novelty, it's about improving return on investment and expanding treatment depth. So at this stage, device selection should be driven by unmet clinical demand and operational readiness, not by technology trends. So this is where strategic additions begin to matter. Although HIFU has a problem about consumables, Actually, HIFU fills a critical gap that lasers cannot address: non-surgical lifting and deep tightening. It responds to strong patient demand for lifting without surgery, particularly in resource-limited settings. Economically, HIFU offers high perceived patient value and premium pricing, while consumable costs remain manageable if carefully controlled. For many clinics, it represents the most accessible entry into the lifting and the tightening market. Long pulse Nd:YAG functions as a safety net in diverse patient populations. It is gold standard for hair removal in darker skin types and is widely used in developing regions. So beyond a hair removal, it treats deeper vascular lesions that IPL cannot reach, such as reticular veins and vascular malformation. Clinically, it expands demographic safety and versatility beyond what IPO alone can provide. Now, let's make it practical. I'm going to propose 3 starter device stacks because the right mix depends on your business reality, your patient mix, pricing power, and how reliable your consumables and the service are. Across all 3 stacks, I'm using the same 4 filters: clinical value per treatment, versatility, safety and learning curve, and long-term sustainability. Stack A is for medical dermatology dominant clinic, a CO2 laser for core procedural demand, plus IPL as a high-volume multi-indication platform. Stack B is the dermatology aesthetic hybrid, IPL for volume, 1064 Nd:YAG laser for pigment and toning, and the low consumable RF for tightening and maintenance. Stack C is aesthetic leaning but resource limited. Start with the resilient backbone and add HIFU or RF microneedling only when pricing and tip supply are truly secured. To conclude, cost effectiveness in energy-based devices is often misunderstood. It does not mean cheap. It certainly does not mean the newest. Across all practice settings, but especially in resource-limited regions, true cost effectiveness is defined by durability and resilience. Devices that keep running, tolerate imperfect infrastructure, rely less on vendor-locked consumables, and can be serviced and taught locally. In daily practice, clinical value per treatment, versatility across indication, safety and learning curve, and long-term sustainabilities are the key criteria to choose EBDs. And of course, the best choice still depends on the nature of the clinic, your patient mix, pricing power, and the core service, but the principles remain the same. Build with platform that service by design. Add conditional technology only when you can control consumables and the service, and introduce high complexity system only when the clinical operationally ready. Ultimately, cost effectiveness planning is not about buying individual devices. It's about building a system that can endure real-world constraints while continuing to serve patients. In that sense, resilience, not novelty, defines true value.
Good afternoon, everybody. At the outset, I would like to thank the ILDS for this wonderful opportunity to speak to the world about a topic that is very close to me. Respected chairpersons and my dear friends, I come from Kerala, which is actually a small state in the southern part of India, which is popularly called the God's Own Country, a tourist destination which all of you must visit at least one time in your life. We all do procedures, we all do surgeries, but then there are situations where we are held up with resource limitations, and that is where we need to innovate. So the purpose of innovation is ultimately to make things easier, and the ability to simplify means to eliminate the unnecessary so that what is basically needed or the bare minimum speaks. So let's start with the procedure room where lighting is usually a problem. So you can look at this one. My colleague is doing the procedure where the headlight, which is actually the cyclist's headlamp, the flashlight which they use, which can be used in our own procedure rooms and with rechargeable battery. It works out very economical and it's available across the online stores. Children are always apprehensive about procedures, and the VR box, the virtual reality box, is now the in thing which every other house may have, and it is again available for very cheap price. You can fix the mobile phone onto that and play a favorite video of the child or a cartoon show or anything like that, and the child can watch that even during the preoperative time and continue to do that, and we can do the procedure at ease without any discomfort for the child, because the sight of the needle is more scary than the pain per se. The magnification is a problem because loops are very expensive. This is what I regularly use it myself, where a +2 diopter reading glass is used. I wear regular spectacles, but I use this above that. So even if you don't have a power for your eyes, you can use this, because our area of working is the reading distance, which is very good for magnifying the fine area where we need to operate. The transillumination trick, where you use a flashlight under the lesion and throw the light through so that you get a good view, and you know how far the wart, perennial wart, is extended. You know how much the ingrown toenail is there, how bad it is. You can show it to the patient very well, and you can also see the extent of the nail involvement on echomycosis. Transillumination is a very simple tool. Next is about small procedures on the scalp. For example, this gentleman had undergone hair transplantation and he had a hypertrophic scar on the donor area which needed intralesional steroids. So for that we use the ultrasound gel, which can be smeared onto the hair, and the hair can be split apart easily. This can be done for alopecia areata injections also. The well of the concha sometimes gets comedones, which are very difficult to remove with a regular comedone extractor because of the pain. So you can use a ballpoint pen without the needle, without the nib, so that you can just punch it in and the material gets extruded very easily. The micropore which we have in our OPD can be used to cover the eyes, which in fact there is nothing great about it, but doing this for every procedure on the face, even if it is not near the eye, helps to prevent the child from seeing the needle, which scares them. So when you're giving treatment for the wart on the feet, and asking them to do it under occlusion, you can ask them to buy a small micropore also. When you want a clean area for keloid surgery on the ear, you can use this micropore to keep the hair away. And next, even for biopsy on the scalp, you can use the micropore to keep the area clean without distractions. The cling film is available in the market very easily. This is used to store food and vegetables in the market, in the stores, but we use it for using topical anesthesia on the face to keep it under occlusion, or even therapeutically when you need medicine to be applied under occlusion, we can use that. And even for the genitalia, if you have 4 days angiokeratoma or something like that, it needs to be cauterized, you can apply topical anesthetic and pack it with the cling film and leave it like that for a few hours, and that gives enough anesthesia to operate. Next is the glove, because the gel pack has limitations. So what we usually do is use a regular glove and put ice cubes. So we don't freeze the glove as such. Instead, we put ice cubes so that the maneuverability is very easy, and you can use it for post-operative cooling. ice pack, and this is even discarded. We don't have to really use it. It's very reasonable and affordable. So some creams come with a nozzle for application. So we take that applicator and use it for topical anesthesia application for in our in-house use. So it's very easy to apply topical anesthetic for DPN and other things on the face, which works out very easy and reasonable. Next, the fine instruments when they sterilize, when they're sent for sterilization, even if you're doing it in your own OPD, they get damaged, chances of blunt or the tip getting broken are very high. So this is actually a tip that comes, the protection that comes with expensive instruments. But for our use, we can use a needle cap with holes burrowed on it, and that can be used 1/3 and 2/3 if you cut and use the lateral 1/3, and you can use that for autoclaving. It doesn't get heated up too much, and the instrument is safe. And the regular stove, the cooking stove, the kitchen pressure cooker can be used for autoclaving. So that is something which it has been time tested, a holding time of about 15 minutes is more than enough for regular autoclaving for most of our procedures, instruments. A glove with a window, because when we are doing a procedure, for example, a phototherapy, a targeted phototherapy of a particular area, or even a narrowband UVB if it is a panel, so it becomes very difficult where you need not to expose unwanted area. So create a window on the glove where you mark the lesion and create a cut so that only the required area gets exposed to ultraviolet radiation. And next is marking the area, because in the fair skin type where it is difficult to delineate, we use this wood slam to mark the vitiligo part and then target it with the excimer or targeted phototherapy. We use excimer now more than anything else. And when we have cryo, now we are coming to the cryo, which is again a very simple technique procedure which is carried out by all of us. So when we are doing a cryo on the tip of the nose, say you get some wart or something like that, it's difficult because if you fire it, there is a chance that the cryogen gets into the nose strip. So instead you can use a disposable cup, the coffee cup, the juice cup which we get in the shops. So create a small window, keep it on to the lesion and fire, so that you fire the cryogen only on the target area. It works out very easy and very cheap. And the moment you start doing it, it becomes very woody hard, and you can press it and keep the lesion inside the window. Next is again a similar technique where you use a bottle, the juice bottle, disposable one. You cut it 1/3 and 2/3, use the upper 1/3. It acts like a funnel. You make sure that you put some holes on that so that the air gets, the excess fumes get removed through the window, and there is no fogging, and you can see the lesion and do. The best part is that the distance can also be standardized. Otoscope has been over the years been used for targeted cryotherapy, and we later modified this with the syringe, cut syringe, the laboratory pipette tips. All these things can be used for targeted cryo on difficult to access areas. Then next is a fractionated cryo, where this has been published, where a sheet, a plastic sheet with fenestration, with holes has been made, and you can use it. The one advantage is like you don't have to wait for the entire 3-4 weeks time. You can mark an area, shoot the cryo this week, maybe 10 days later you can call the patient back again and shoot another area with the marking if you have a standard technique for that, so that you get quicker procedures without much delay. So when you have a mucocele or a pyogenic granuloma on a child's face, on the lower lip especially, so it's very difficult to hold the lip. Instead, you can use a micropore with a window, use adhesive, pull it down and fix it, and then you can use the cryo. Next is the regular whatever adhesive plaster which you get in the store. That is sterile also, which is used for procedures near the eye or on the scrotum, or even a small biopsy where you don't need expensive dressings, and it just stays there for 1 or 2 days and the patient can pull it out himself. So next is when you are not very sure about the depth of penetration for the intralesional injection, you can cut the needle cap to the size distance which you need, and do the injection. So that works out very well. It's like a guard with a needle cap, with a needle cover. And the toe space maceration and tinea pedis and other people, and sometimes you get a hard cone also there. So such people, it's very common in our part of the world where the humidity is very high. So you can use a copper wire and wind a adhesive plaster around it and create a device with a fixed distance. So the patient can wear it every night, and that keeps the toe space separate. And also you can apply the medications into the gap at ease overnight. And similar way, you can use a toilet paper roll. You can wind it like this in a double helix pattern, and that also gives the gap enough, and also the humidity, whatever moisture is there, absorbed by the tissue paper. So what happens is the next day morning they can just throw it out. So it's very easy. There is no problem. Sometimes you get infections at the tip, so of the toe, where problem is that the toe may be falling down due to some neurological defect or something like the foot drop. In such situations, you can use the plaster like this in a pattern and keep it like that. The patient gets a splint-like mechanism. So this is actually available in the online stores, where the scissors get a magnifier. This is a sewing. It's a household thing, where you can remove that glass magnifier and place it on our EC, where you can see the lesion very closely, very well, and in a bigger magnification, and do the procedure at ease. The gooseneck, again, this is actually used for the laptop, for brightening the keyboard when you're traveling. That can be used for the electrode to brighten the area where you are operating. Tick is a very common problem in our tropical countries. So ticks, so removing the tick, if you don't do it properly, what happens is the disengagement doesn't happen. So if you don't remove it properly, chances of a granuloma formation or even an infection is very high. So we can use the radio frequency, put some local anesthesia, use the radio frequencies to just touch it, so that the tick gets disengaged, and it gets adherent onto the tip, and it just comes off with the radio frequency. Maybe you can shoot one more at the end of the session, where at the bite mark, where that can also act as a sterilization. The smoke evacuator is very expensive, and that's a problem, especially when you're doing cautery of the wart and other things. So the regular smoke evacuator can be expensive thing, and it's a space constraint also. But the regular kitchen chimney, it can definitely reduce the smell. But it is not an equivalent to the smoke evacuator, but it is definitely better than not using anything. So that you just switch it on, and the smell gets sucked into the chimney. This is an interesting procedure where the slit skin smear, that has been done. We conventionally do it with a blade. So this one, instead they used a surgical scissors, or a small scissors, which can be sterilized, and with that they put a nick, and a slide is used to take the smear impression. And disposing the ampule, and also opening the ampule sometimes is a problem. Even the ampule remover sometimes will not work out very well. Instead, you can use the local anesthesia bottle. We have it in our OPD in plenty. So you punch and create a punch hole in the middle where the rubber, and then you can use this. And the best part is that the cut part goes inside, and that stays like that. Once that is filled, you can throw it out entirely. And or in the sense, you can send it for the biomedical recycling, the biomedical people correctly. So there is no harm, and even the injury does not happen during the procedure. The PMMA is the polymethyl methacrylate, which the dentist use for creating the dental dentures and other things. So you can take the help from your dentist friend to create a clip device like this, which acts as a self-retaining pressure clip for a keloid surgery. Because if you, however beautifully you do the keloid, unless and until you put the pressure, the chances of recurrences are very high. So this is a very good technique which you can try in your place with your dental friend. And topical 5-fluorouracil is a time-tested medicine for vitiligo. So if you can do some needling into that, the chances of 5-fluorouracil getting into the surface of the vitiliginous skin is high, and the results have been promising. The dermabrasion, if you are into vitiligo surgeries, ordinary sandpaper, this can be ETO sterilized. So it's very easy. So if you have a friend who can do this for you, use a poster, send it across to him. He can do that and seal it and send it back to you. And you don't need electricity at all. You don't need a dermabrader. You just hold it in your hand and just rub the surface. There is no problem. It is absolutely safe. And you get a clean recipient area, dermabrasion of the dermabrasion of the vitiligo surgery. So I think I'm coming to the end of my lecture. So my take-home message is like, I want you all to innovate. There is room for innovation even in everyday situations. Don't hesitate to experiment on seemingly, it may seem idiotic. The idea may seem idiotic for you, but don't hesitate. Don't make don't wait for somebody else to make your life easy. You have to innovate yourself and move forward. Thank you very much for listening. These are my friends at work, my colleagues. Thank you very much. Once again, thank you all for the opportunity and good luck to you.
Hello, I am Ivonne Arellano. I am a dermatologist and dermatologic surgeon based in Mexico. And for many, many years, I had an institutional practice. And from there, I can tell you that I have chosen some tips or counsels to optimize skin biopsy under surgical constraints. I thank you very much for this very kind invitation, and I hope this presentation is useful for you. The first thing I want to say is that skin biopsy is a surgical procedure that removes a small and valuable tissue sample of the skin for evaluating skin and systemic diseases with cutaneous manifestations. It is very important that to decide to perform a biopsy, you need to have a clinical dermatological diagnosis. It is mandatory to do it if the result is going to impact the treatment you are going to prescribe. And the election of the lesion is very important to perform the skin biopsy. The location, depth, and breadth of the sample you are going to take is very, very, very important to be chosen adequately. The technique you are going to choose to take the sample, and of course, handling the sample or the specimen is very important for the outcome of this very important diagnosis. Many times we take for granted that skin biopsy is a very easy to perform or to find procedure in many countries, but it is not true. See this very nice study in which skin biopsy equipment availability across 7 low-income countries was studied. See how 6,053 health facilities were studied. And you can watch here that surgical biopsy availability was only in 23.7% of the centers, and the surgical biopsy available and the procedure free for the patient is even more scarce, 4.5%. So when we see what are the possibilities of this elemental equipment to perform a biopsy can be found in clinics, health centers, or hospitals, see how it's very variable. So you need to look that or to try to get in every center hand wash, latex gloves, skin disinfectant, of course, local anesthesia as lidocaine, single-use needle syringe, scalpel blade, surgical scissors, needle holders, and non-absorbable sutures and sharps containers. Some basic knowledge is very important to perform a biopsy in an adequate way. Basically, these concepts, we have to have them learned from medical school, and it is topographic anatomy to identify risk zones of arteries, veins, and nerves. And also, it is very important to have the knowledge about these tension lines, because the suture that we put in this wound, although it is very teeny, it is very, very important to be aligned with this to have a good cosmetic and wound healing result. Previous to the procedure, it is very important to evaluate the patient for possible complications that are very few, but it is mandatory that you do it as part as your medical attention. And you have to do a complete clinical history, mainly interrogating allergies, the previous use of anesthesia and possible adverse reactions. If the patient is having medication as mainly anticoagulants or herbal remedies, we should advise him always to avoid to razor the site of the biopsy. The informed consent is very important, not only for the procedure, but to utilize his clinical pictures, because remember that most of the diagnoses that are important for inflammatory diseases are clinical, pathological. So we might need to send the clinical pictures to our dermatopathologists to do a good correlation. Then it is very important that you assess with the patient his capability to take care of the biopsy site and the capability to come back for his results and the stitch removal. All of this you have to do in a written instruction so that the patient will not forget and will do everything that is important to avoid wound infection. The site selection is very important for tumors as melanoma, basal cell carcinoma, or any other tumor. It is very important that if you can, you will try to do an excisional biopsy. But if not, if you are going to do an incisional biopsy, do it of the thicker part of the tumor. If you are going to investigate for a bullous disease, try to get a new and complete lesion so that pathologists can assess quickly and easily with hematoxylin and eosin, and also immunohistochemical techniques. If you are thinking about a vasculitis, you need to do a deep biopsy, having subcutaneous tissue and of a new lesion. And you have to select very carefully the technical biopsy consideration. So you will choose amount: shave and sterilization, curettage, scissor biopsy, punch biopsy, incisional or translational, and excisional biopsies. See some examples. Here we can see a shave biopsy of a pedunculated lesion. See how it is very easy to do it just having our scalpel blade horizontal and parallel to the skin. See how we have to be sometimes inventing alternative use of the things we have available. As for example, here we don't have this Adson forceps, and we can substitute this to not to preserve the tissue that we are going to remove with a needle. And see how it is really very easy to perform this kind of biopsies. Almost no bleeding is on the surface of your wound. Another variant is auxerization that can be done, of course, with these special blades, but you can also sterilize very carefully these razor blades and do it as well. The only thing that is very important is that you tell your patient that you are going to leave a depressed scar. Many times it is in a different color of the rest of the skin, and some patients are really concerned with this. Also can be done with curettage or electrobisturi, that is also variants of these techniques. The scissor biopsy, it is very, very easy. The only thing that you have to be careful is not to squeeze or destroy the tissue with the Adson forceps. So it is very important so that you can have a right pathological assessment of the piece. The punch biopsy, it is really not an expensive instrument, but it is important that when you previously have infiltrated some local anesthesia, you wait until hemostasis is done, then you turn the punch always, as you can see here, only in one direction, because if you turn it in both directions, that tissue will be destroyed. And then get it up with a needle or add some forceps and cut it with your scissors. See that you will leave a wound that can be 3, 4 to 5 millimeters. Many times you don't need to suture, but if you do put one stitch, you will remove it in 10 to 12 days. If you are thinking of a deep alteration, it is important to do your biopsy down to the subcutaneous tissue. You can do it also with a scalpel. And when the tumor is too big, always do it in a wedge and have the normal skin and part of the lesion that you are going to study. This is important for tumors, and these deep biopsies are indicated in paniculitis, for example, and to try to get a most accurate diagnosis. It is very important that an undesirable result of this harvesting of the specimen would be that you have a broad and shallow sample, because the desirable one is to have a narrow and deep portion of a lesion. Sometimes you need to do translational sections, as for example, if you are trying to diagnose a keratoacanthoma. And sometimes it is better to excise the complete lesion and see that with 3 or 4 stitches, you will have resolved completely most of the lesions that have 1 or 1.5 centimeters. Always go deep until subcutaneous fat. The management of the biopsy sample is very, very important. We use formol or formaldehyde, 10%. The amount of liquid should be 20 times the size of the biopsy. It is very important, as crucial that in the moment you put the sample, you rotulate this container that you are going to use with the name, gender, and diagnosis, clinical diagnosis, but mainly the part of the body that you are going to sample. Don't put biopsy number 1, biopsy number 2. No, always put right hand, left hand, forefinger, the exact site, so that your pathologist will have not problems with identifying the piece with the clinical history that you are going to adjunct. It is very important that in some settings, a skin biopsy is a real luxury, not a routinary procedure. Unseen costs have to be taken in consideration, as transportation, salary loss, repetition of the procedure when needed for the patient. It is terrible. If you have technical inappropriate issues, it is often necessary to require repetition of the procedure. So it is very important that you do it well from the start. And in the worst case scenario, would be an insufficient sample that leads to a poor diagnosis. Also, there is no need to perform a biopsy if your diagnostic approach is fully supported. Perform a skin biopsy only when the histological diagnosis changes your therapeutic approach. Prioritize biopsies that are needed for prognostic sustentation of your systemic and treatment and or helps to avoid prolonged empiric treatments. Ask, or you need to ask for special histologic techniques only if your clinical diagnosis requires, as for example, when you have a periodic acid of Schiff, a Fitte-Faraco, Seale-Nielsen, immunohistochemistry, etc. See that there is a great utility of international store and forward dermatopathology, and here is one of these very nice studies that can be done, and that it is very important to have a center in which we can refer these samples, mainly when you have infectious diseases and you need special stains and cultures, when you have the inability of performing immunofluorescence studies or immunohistochemical stains. It is very important that you remember that we are a lot of member societies. Our International League of Dermatological Societies has grown by 61.5% in the last 3 years. And we have many programs that can facilitate your access to teledermatology, telepathology, and many other educational support. One of them is the Global Partnerships of Education and Care Program, also called the GPEC program. Here, the aim is to improve the standard of dermatological education and care worldwide through facilitating mutual learning and partnerships between international institutions. Our partnerships for this cycle are just starting in this January, so it is important that many hospitals are having an exchange for 2 years, and I think it's a very important support in all these procedures. And I just want to end thanking you for this kind invitation. I hope these tips can help you in your everyday practice. And remember that a skin biopsy should be available for every single patient that needs it. Thank you very much.